interesting that women and men have different carrying angles. They also have different hip anatomy, and therefore the corresponding upper extremity matches the lower extremity anatomy or the functional demand for that particular individual. So when I move into this valgus orientation, when I flex, I can't stay out here in space. Otherwise, I miss my mouth. So the elbow has to come towards the face. So therefore, the carrying angle is reduced from a valgus angle to a neutral, even into slight varus, as the elbow comes to the face. So when I do functional activities, the carrying angle has to be reduced to a neutral angle so that the hand may approximate the face, the head, or whatever functional activities. Remember, the purpose is flexion. Elbows are constructed to bring things from the environment to the person, not push them away, although it does have a pushing function, but the main reason is to bring things towards you. I always say that it's so that we can finally actually reach that banana, peel it, and bring it to our mouths. That's why we have an elbow constructed the way it is. An interesting perspective is primates are the only species that actually bring their food to their body. All the primate species which have mobile functional elbows use that as a way of bringing the terminal unit to the body. And so therefore they're the only animal species that allows the food to come to them as opposed to they going to the food. If we look at this in the AP plane, you can see we have a nice reduction. The elbow is held distracted but yet stable, and this allows the patient to begin an early active motion program. Now the problem sometimes, of course, is that the person develops the pattern that you saw way back when we saw Our Lady moving on the tabletop. This patient has the same co-contraction issues and has the same early mobilization issues to gain extension, so he cannot fire the tricep. So therefore they're posturing into too much flexion. So one of the things we did with this person was we created a very early onset of orthotic management as a way of preventing significant elbow flexion contraction. And let's take a look at that. So here we have a modification of an anterior-based orthosis that I'm going to apply. So this is the anterior-based orthosis, and you can see that there's a little bubble shell at the orthosis that allows the elbow to straighten when I apply a posterior force. Now we're going to go through orthosis in just a few minutes, but I just wanted you to see this in context of this case. So here's the orthosis in place, and so what I do is I apply that as a 3-point orthosis over with an ace bandage, simply with an ace bandage, and this is how the patient would sleep at night. Okay, so they would be positioned in this device at night, so when they begin to relax that biceps co-contraction, the ace bandage allows the elbow to straighten. There's no restrictions in motion on this because the external fixator is holding the joint in a perfectly reduced position. Now, the secondary muscle, if you think back to the lateral side, just to refresh, on the lateral side we looked at the extensor carpi radialis brevis and the secondary muscle of the extensor digitorum. Here our secondary muscle, primary muscle is pronator teres, but our secondary muscle is flexor carpi radialis. Now, just a brief technical point. The flexor carpi radialis inserts to the base of the second metacarpal. So here's her second metacarpal right there, and I'm going to track back down, and the base of the second metacarpal is right here. So that's the origin the insertion point of the flexor carpi radialis. I like to start my patient with the patient in full flexion. It brings the tendon up nicely. There's her flexor carpi radialis tendon right there. You can see that coming right up very nicely. And I will hold that second metacarpal this way. But in this case, I want the elbow in full extension, so I'm going to want her there.